Hi, wonderful labor and delivery nurses. I'm so sorry that I missed this fun project of the physiological birth today. I'm on vacation. Woohoo! So through this video, I'm going to give a presentation of the occipital posterior position and how to manage the labor with the OP position. I hope you enjoy it. So let's go over the basic information of OP position. So incidence of the posterior position is about 5 to 12%. Possible etiology is shape of pelvis, anthropoid pelvis. Race, non-Caucasian group has a higher incidence of the posterior position. Nulliparity, most twice of the multiparous. BMI over 30, age over 35 years old, labor augmentation, anterior placenta, and early epidural, and amniotomy. Those are the all etiology of the posterior position. Epidural itself doesn't cause malposition. However, one study suggests that the delaying epidural until patient is 5 centimeters and plus minus 0 station may help to decrease the OP position. As you see in this slide, the majority of the baby rotates spontaneously to OA during the labor. Even baby starts descending on the second stage in persistent OP. Among those baby, 50 to 80% of the babies spontaneously rotate to OA while the patient is pushing. So what's the impact of the malposition or the persistent OP? It increased the operative vaginal delivery rate almost up to 70% and higher incidence of the cesarean section. If patients go to C-section after the few hours pushing, because baby's head is so wedged into the low pelvis, they are more likely to have a blood loss from the extension of the incision. Therefore, the baby has more risk for birth trauma and low Apgar score and acidemia and NICU admission. So what's the sign of the OP you observe at the bedside? For example, irregular shape of the abdomen, scaphoid abdomen, prolonged labor, labor dystocia, persistent anterior lip, fetal heart rate detected extremely lateral location, back labor, dysfunctional contraction pattern, you see doubling, tripling, couplet contraction patterns, early rectum pressure, premature urge to push, recurrent variable decel, which is very also common. When you see those signs, you have to confirm the baby's position. The easiest way is digital exam by identify the front fontanelle. However, the digital exam error rate is 26 to 39%, pretty high. So the golden standard of the diagnosis of the posterior position is the by ultrasound. Although sometimes it is difficult to identify the fetal position by ultrasound because of the baby's head is so molding. So this is the image of the OP by ultrasound. Left image is the direct OP, right image is the LOP. So how can change OP to OA? I personally believe that the bedside nursing care based on the understanding of the anatomy and the physiological process of birth is the key. You're the person who can make a change. Let's go over the 5 basic elements of labor. Number 1, power. This is very important element because of the OP baby has a prolonged labor and then uterus contraction is often very weak. So patients need a strong IUP. By using IUPC and then increasing the pitocin, uterus can maintain a strong power to push down the baby and rotate the baby. Number 2, passenger, which is baby. EFW is adequate. Baby's heartbeat tracing shows the good reserve of the baby's well-being. Number 3, passage. The pelvis is important, but more important thing at the bedside is empty bladder of the patients. Number 4, psyche. Patients still have a good spirit to push couple of hours. She might be exhausted. She has a good support. Number 5, position. Maternal position and movement change the force of gravity, pelvis dimensions, and various pressure within the uterus and pelvis joint. The position of the baby is influenced by those forces. And lastly, provider. Some provider is comfortable to do manual rotation. Some people don't. So it depends on the provider you're working with. How to facilitate the fetal rotation by changing maternal position? If patient is in labor with epidural and rest on the bed, semi-prone position is one of the most powerful positions to rotate the baby. Patients is in this position, patients is lying on the side, but mostly almost like lie on her belly. If patients is labor without epidural, changing the position frequently is the key. Hands and knees and chest knee position is really helpful to reduce the back pain and control the rectum pressure, but most of the research shows that this position does not rotate the baby. Regardless the stage of labor, it's very important to change the position frequently. If the one position does not turn the baby, try the other side. On the second stage of labor, pushing position is also important to facilitate the rotation and descent. Side position, lotus position, macrobats like flat position is help to have baby come around the pubic bone. Most important thing you have to know is if the one position doesn't work more than 30 minutes, change the position to the other in 30 minutes. And try another 30 minutes. If doesn't make any descent, please call provider and have her evaluate.
Good? Okay. So here is the OP baby look like in the pelvis. So to rotate the baby, if you want to lower the more prone position, actually you can bring the patient's shoulder back and then put the legs on the side table. And then hopefully this brings the baby's rotate. Like this. For the runner's position, people like that.
This is the image of the prone position. It's different from the side position. It's almost on her belly.
And action.
Okay. So sometimes I see that patients is resting with the epidural like this way, and then with the using peanut ball, and then resting up the leg. But this is really not working well because the baby's heavy part is still on the lower part, on the low side, and then the baby needs to really rotate this way. So the you can remove the ball, and then you have to bring the patients really turn to the side way. In this way, the gravity brings the baby rotate. Oh, this baby doesn't rotate. Doesn't this way using the power of the gravity. So baby needs to, mommy needs to really rotate almost on her belly.
Now I'm going over the pushing position on the second stage, but before that I want you to take a look at this image. This is the image of the baby OP rotate to OA in the outlet of the pelvis. As you see, the baby changed the angle under the pubic bone almost 90 degrees to come out.
Now I'm explaining to the how to push the baby. From the side, babies just look like this. You have to remember the baby's head is coming outlet of the pelvis, almost like a 90-degree angle. So for the OP baby, it's really hard to go around the sacrum, and then also because of the front fontanelle is giving so much pressure from the pubic arch. It's very close, like a terminal D cell a lot. So to help the baby is go around the outlet to almost 90 degree, come like this. You can do a couple of things. One is definitely upright position. It doesn't work because baby needs to really coming like this way, and then it's cause a lot of decel. So when you're doing the upright, if your patient is on her back, you can lower the head down, and then when you bring the legs up, almost like a Mark Roberts, can you see the pelvis angle is moving up? So the baby is gonna help to go around the pubic bone more easily. So the lower the mom's head down, and then bring a leg high, which definitely change the pelvis angle more upright and towards the ceiling, and then easy to baby come around. And
Pulling the woman's knee towards her shoulder rotates her pelvis posteriorly, flattering the low back and moving her pubic arch towards the woman's head. This may allow the fetus to slip under the arch and continue its descent.
And the other position is called lotus position. When the patient has a good flexibility of the leg, you can have them to hold the ankle, and then when they push, they can move the ankle towards the chest or head. So can you see the pelvis is moving up? And then this position is just the same like a macro guards. It's easy to baby go around the pubic arch. Sideway is also helpful. When you push on the side, make sure the butt is off the bed, and then this way it's really help to release that pressure from the rectum from the bed.
Again, if 30 minutes pushing in one position doesn't work, try to change maternal position and in the different position another 30 minutes pushing. If still doesn't work, call the provider so provider can evaluate try manual rotation before the fetal head is deeply wedged in the pelvis. Thank you for your attention. If you have any question, please let me know. I'm looking forward to hearing your experience. If it works or not, let me know. Thank you.